This patient was referred to me for endodontic retreatment of tooth number 14. According to the patient, the root canal was done a few years ago. As you can see, PFM crown on the tooth, previous root canal, and periapical lucency. The distal buccal and palatal canals are okay. I don't see any periapical lucency associated with them. But as you can see, there is a periapical lucency associated with the mesial roots. All right, so again, I emphasize on not relying on just one angulation PA. Take one mesial, one straight on, and one distal angulation at least. So you kind of know what you're getting yourself into. For example, in this case, if I just rely on one angulation, look what I'm missing. Okay, let me show you a different angulation PA. Check out this angulation. Look at that 90-degree curvature of the MB1, and of course you can see the missed MB2 right there. So this dentist who did the root canal missed the canal, and also of course instrumented and obturated the MB1 short. Left necrotic and bacteria, necrotic tissue and bacteria behind, and that's what's causing that periapical radiolucency, that lesion there, that apical lesion there. So missed MB2, and because of the 90-degree curvature of the canal, I can tell this dentist didn't have much experience, didn't know how to handle a curvature like that, so decided to go at an instrument and fill short, and as I said, also missed an MB2 canal. All right, so take multiple angulation PAs. Otherwise, you would think that the tooth, that mesial root, has a pretty okay curvature, not realizing that that curvature is actually a 90-degree curvature, and what will happen is you will break a file. You will break a file, okay? So we went ahead and discussed options with the patient, and the patient decided that she wanted to go ahead and try to see if we can save the tooth. So went through the crown here, and I did selective endodontic retreatment. There was no need to remove the gutta-percha from the distal buccal and palatal canals. As I said, this root canal was done a few years ago. The problem is not the distal buccal and palatal canal. The problem is missed MB2, short instrumentation and obturation of the MB1, which means that the dentist left necrotic tissue, pulp tissue, and bacteria behind. Okay, so we're gonna just work on the mesial canals. And here's the post-op, so take a look. We were able to regain patency in the MB1 canal, located the missed MB2 canal system, and as you can see, the MB2 canal system is completely separate from the MB1 canal. So MB2 doesn't join MB1, has its own canal, completely separate canal. Everything went great. We went ahead and temporized the tooth and referred the patient back to her dentist for the permanent restoration.